Hi, everyone. My name is Dr. Lily Brown, and I'm the director of the Center for the Treatment and Study of Anxiety. Today, I'll be presenting to you a brief podcast to talk a little bit about understanding suicide risk and suicide risk assessment. To begin, I think it's helpful to talk about a couple of different theories that can help us understand what's happening for people when they're starting to think about suicide or when they actually are wanting to act on those suicidal thoughts. I think it's helpful to understand these theories because it can actually reduce the stigma that people have toward people who are thinking about suicide and the shame of loved ones and people with lived experience with suicide risk. One theory is called the three-step theory of suicide. This theory, developed by David Klonsky and Alexis May, suggests that people might start to think about suicide when they have the combination of pain, which can be psychological or physical, plus hopelessness about that pain, which looks like this is never going to go away. Connectedness can be something that can protect people, though, and that connectedness can be to other people, but it could also be connectedness to meaning in life, a sense of purpose, or connection to a person's values. Connectedness is thought to protect people against developing more serious or severe thoughts about suicide. And then in this theory, there are a number of factors that are thought to predict whether someone might actually make a suicide attempt. And these can include dispositional factors, which is basically what you're born with, your biology, your genes. Acquired risk factors, which are things like exposure to violence or exposure to trauma. And practical risk factors, which could look like owning a weapon or having easy access to a lethal mean. To give you an example, a person might be struggling with symptoms of PTSD or post-traumatic stress disorder and might feel pain in the form of a startle response, feeling like I just can't relax, everything makes me jump. They might start to have thoughts about that startle response, like my life's never going to get better. People with PTSD also start to feel like I just can't relate to people in the way that I used to. And people who are feeling that way might be starting to have more severe thoughts about suicide. In the case of PTSD, exposure to violence or trauma is an important acquired risk factor, something that you experience during the course of your life. And a person who's been exposed to a trauma might be more likely to own a firearm because they're feeling unsafe in their world. But owning a firearm can put them at higher risk for making a suicide attempt. Another theory that's important to think about is what's called the interpersonal theory. And according to this theory, people who think about suicide have two key considerations, both of which relate to other people. The first is feeling like a burden on other people. So we call this perceived burdensomeness. The second is feeling like you just don't belong. According to this theory, it's the combination of feeling like a burden and feeling like you don't belong that makes you think about wanting to kill yourself. Fortunately, most people who think about suicide, though, don't make a suicide attempt. According to this theory, the people who are more likely to make a suicide attempt have a combination of fearlessness about death and reduced pain sensitivity, meaning they don't feel pain as strongly as other people, which could actually have a consequence of making suicide attempts more lethal. There are some facts that are important to consider. So about 60% of people who die by suicide die on their first attempt. Most of these people, or at least many of these people, have never sought suicide prevention treatment. They've never gone to a therapist to say, I'm here because I'm thinking about suicide. But often in the Penn system, we will encounter people struggling with suicidal thoughts in other places, like in primary care or at their annual OBGYN visit. The factor that's the strongest predictor of a future suicide attempt, though, is having a prior history of an attempt. Fortunately, 90% of people who survive a suicide attempt do not go on to die by suicide. So there's lots of reasons to feel optimistic that things could change to help a person feel like their life is worth living. But we think about suicide death as a product of both one's intention to die and their access to lethal means. Just because someone has a strong intention to die doesn't necessarily predict the risk of dying if their choice of suicide method is not as lethal. We also know that suicide risk can fluctuate quickly. So it's not like there are low risk people and high risk people. A person who might be at high risk today might look lower risk tomorrow, and then the next day might be at higher risk again. There's a lot of data to back this up, including data from my own lab and from the labs of other people here at Penn and elsewhere. Michael Perlis here at Penn has published some really important data that looks at the timing of when suicide deaths occur and accounting for, the probability that someone's awake at a given hour. In his study in the general population, he found that most suicide deaths occurred between midnight and 4 a.m. So you could think about this as potentially, as he titled his article, it might be risky to be awake when your executive functioning is supposed to be asleep. There are some strategies for evidence-based suicide risk assessments that I want to alert you to. In general, if you're thinking about asking someone about suicide, it's helpful to take approach of being, gentle and having curiosity about it, but not being judgmental. It can also be helpful to normalize, to talk about how it's not uncommon for people to think about suicide from time to time. And that's why you might be wondering whether your loved one is thinking about that or struggling with that right now. It's also helpful to be honest about your perception about when hospitalization for suicide risk is a good idea and when it's not so helpful. We often think about hospitalization as a Band-Aid to help someone survive, but we know it's not a long-term solution. And it's helpful just to lay that on the table, that if there's something we could think about to help you feel less suicidal now that doesn't involve the hospital, that might make a lot of sense to try that first and to sort of treat hospitalization like a last resort, but necessary in some cases. There's a project developed by Columbia called the Lighthouse Project. The chair of our department, Maria Okendo, and a brilliant suicidologist, Greg Brown, in our department, has done a lot of research with this organization where they've published a tool that can really be helpful for formalizing ways to ask about suicide for those of you who work in a clinic. And there's helpful links on this website for resources, whether you're working in research or clinical practice, and also getting some online training for free in how to ask these questions. In brief, one version of this measure asks a series of questions that escalate in terms of possible risk, ranging from thoughts about wishing one was dead or wishing they could go to sleep and not waking up, actually having thoughts about killing oneself, and then escalating further to thinking about how you might do this, and then further still having some intention of acting on those thoughts, working out the details of how to do that, and starting to do anything or preparing to do anything to end one's life. As you can see here, the risk here is escalating from relatively mild to moderate to more extreme, which can help you in making decisions about best next steps. Lastly, I'll mention that there are some factors to consider when we're talking about suicide risk. So alcohol is an important consideration here. In a large study of over 300 individuals, about a third of people reported drinking alcohol before their suicide attempt. And of those who did drink, 73% just happened to have been drinking and then decided to make a suicide attempt. It's not as though they were drinking to die by suicide. And that makes a lot of sense because it's likely that drinking alcohol can reduce inhibition and can make it harder to get in control in terms of emotions and harder to get in touch with why your life might be worth living. And so this is an important factor to consider. Greg Brown and his colleague Barbara Stanley have also developed a brilliant, brief, collaborative tool to use with patients and with people for helping plan for future suicidal crises. And this plan is what he calls a safety plan. And I've heard that there is an EPIC template that's being rolled out to be able to use this in your clinical documentation. This looks like asking about warning signs for suicide, strategies to distract yourself from thinking about suicide, people and places that you can interact with to distract yourself, people in your social circle to whom you can reach out and say, hey, I'm having a hard time, I need help. Professional support services, I'll provide you with some resources for that as well. And lastly, steps that you can do now to make the environment safe so that if you're in a future crisis, you have some obstacles in your way to prevent escalation to actually having a suicide attempt. There are some really great resources in Philadelphia for things like getting gun locks. I'd encourage you to look into videos about how a gun lock works, because there's a lot of research that shows that safe storage practices, including gun locks and storage chests and safes for guns, can reduce risk when people are feeling suicidal. And so those are important considerations to know about. Lastly, it's important to consider that you don't want to hide an unlocked gun. There's research that shows that everyone in your family knows where it is, even if you don't think that they do. It can be helpful to involve a support person when you're asking folks about suicide risk. It might be helpful to consider getting rid of excessive medications you don't need. It might be worth it to think about weekly dosing through your pharmacy of medication as opposed to monthly dosing. And it might be helpful to set some reminders up for yourself about why it's important to you to keep living. What makes your life valuable? What are your reasons for living? Like a Post-it note with the people who are important to you that you might post on the dashboard of your car, as one example. I've included here some links to resources that you might find valuable. And at the end, I've also included some additional resources, including the 24-hour mental health delegate line, and resources for additional training in how to become a gatekeeper for suicide prevention through the iCare program, through Penn's CAPS program. Please feel free to reach out if you have any questions about this or looking for services here at Penn or outside the Penn community. And thank you for joining us today.